let me add my welcome to all of you and sort of underscore the importance of the transplantation program at Downstate and more importantly for this community. One of the things that we want to stress is our service to the community and the critical importance of us bringing the types of services that are simply not available anywhere else in the community and to really complement our partners that are in the delivery system, in part by really increasing the academic context and the quality of what's offered, but in a case like with transplant services, by being the unique provider of those services in a way that we can really serve Brooklyn. So I think it is tremendously exciting, but I think a key issue is our ability to make sure that we have this type of programming so that anyone from the community, as well as the academics here, can share in the current developments and the directions for the future. So I hope you have a great meeting, and thank you so much for coming.
The president might pop in at any time, so we will probably halt when he comes in, just for him to give a few remarks. In the absence of that, I'll turn this over to Dr. Tedler, and then he would continue from there. Thank you.
We have the new chairman of surgery, Dr. Rainer Grusner, who I would invite to make a few opening remarks before I make some opening remarks. Dr. Grusner, please.
Thank you, Dr. Tedler, and welcome. I'm obviously new to Downstate, but I chose Downstate for a reason. It does have a long-standing history in transplantation. It was one of the first institutions that performed over 1,000 kidney transplants about 20 years ago. And it also was an institution that early on embarked on multivisceral transplantation, including pancreas and liver transplantation. And then over the years, for many reasons, it did not follow through anymore. But one of the first pioneers in transplantation, Samuel Kuhns, was the chair of the Department of Surgery here. And he played an integral role not only for transplantation here downstate, but for all of New York City, New York State, and in the country. And we want to continue with that tradition. So our goal is to make Downstate, over the next few years, the center for diabetes, or transplantation in diabetes in New York City. We have a borough with one of the highest incidence of diabetes, not only in New York City, but in the country. But we want to get back to where Downstate once started, and that is multivisceral transplantation and all types of a comprehensive transplant program, including pancreas and liver transplantation. So this is hopefully what you're going to witness over the next few years. And I also want to briefly mention that over the last few years, with Dr. Salifu, Dr. Devin John, the entire team, Dr. Tedler, there have been remarkable progress also already in the field of transplantation here. I also would like you to come here as speakers or to listen, because as you know, transplantation has undergone a remarkable evolution over the last 50 years. And communication with each other has helped us to propel this field into what it has become, from an unregulated to a very regulated field, with excellent results, with excellent patient and graft survival. And this is due to the communication and to the information that is shared at these meetings. So again, welcome, and I hope you will have an enjoyable Friday the 13th. So again, welcome.
All right. So I now have the privilege of introducing our distinguished president. He's been with us for 7 months, and he's bringing a change to Downstate. We're so proud to have Dr. Wayne J. Riley as our president, and he's come to share his thoughts with us in terms of his strategic planning process. So thank you, Dr. Riley, for coming.
Thank you, Dr. Southwell. Good morning. Welcome to Downstate and this great Department of Medicine, is this great effort to improve transplant care. I am delighted to be here to bring words of welcome, but also to highlight the importance of what you're doing in a very important patient care issue that we know we faced here in the United States, around the world, in fact, and more particularly here in Brooklyn. This institution has an outstanding history in terms of nephrology You have one of the Downstate legends to my right there, Dr. Friedman. And I was delighted to visit with him very briefly last Friday. I just walked into his office, and I think I startled him. But no, he's one of the legends. But we have such great history in terms of transplant here. And in fact, my own family, my wife, her late aunt, had 2 kidney transplants here under Dr. Sam Kuntz, who's one of the giants of the field. So my own family member has benefited by kidney transplantation. So this is an incredibly important effort that I think we have, as they say, academic and clinical street credibility. And it's my discussions with Dr. Grusner, our chair of surgery, and Dr. Salafu, our chair of medicine, that we continue to enhance our ability to offer high-quality transplant care here at Downstate Medical Center. So I'm just here to say thank you for what you're doing, for your passion, for your interest, and your drive to make sure that our patients and the patients that you serve, wherever you take care of patients, get the best kidney care possible, best transplantation, pre-transplant, post-transplant. As a general internist, I've had opportunity to work alongside my nephrology colleagues in caring for patients who've had kidney transplants. So I know the expertise and the precision in which you pursue transplant medicine. So again, I'm here just to say thank you for what you do and to salute you for what you do. So thank you. Have a good conference.
Good morning again, and welcome to the audience and to our guest speakers to start our symposium. Just a few housekeeping issues. Today's symposium would be live cast. This is the website address if you have colleagues or friends who would like to join and they cannot be here in person. They can see the live stream from this site. And during break, we will have refreshments from the same room that you had breakfast this morning, and then we will have boxed lunch for the audience during lunchtime. Just to set the stage for the upcoming speakers and describe the theme of this conference, I would start first by acknowledging the people and entities that support the symposium. It is made possible through the departments of medicine and surgery, and also through support from educational grants from Gilead and our exhibitors outside. We have Lemed Pharmacy, Mallinckrodt, Veloxis, Alexian, and Urlipsa. This is a statement made about a century ago by Sir William Osler describing the prognosis of somebody with kidney failure. And it's been true for up to 50 years after this statement was made, when the advent of dialysis gave hope to patients with kidney failure and allowed transplantation to happen. And it wasn't the same way as we have it today. Almost every paper you read starts by saying on transplantation that kidney transplantation is a preferred treatment, but we had a rocky course as we start. As you see here, the up here on the yellow is the rejection rate, and in the green was the 1-year survival rate. And you could see what kind of transformation kidney transplantation and by way of kidney transplantation, other organ transplantations went through. Today, we have graft survival rate at 1 year in excess of 90%, and often more than 95% in live donors. We have rejection rates, and this mentions 15%, and now it's even lower than that. And a lot of this happened because of our better understanding of immunosuppression and the kind of agents we have available. But in parallel with that is also developments in organ preservation. As many things in transplantation, some of the seminal observations were made by Alexis Carrel, who in this paper in 1912 mentioned the role of tissue preservation in organ transplantation and had experimental examples of that. And fast forward to about 50 years later, and you see this contraption that was made by Soviet scientists, which is very analogous to the heart-lung machine in cardiac bypass. And they used cold perfusate with pumps and oxygenator to perfuse here the hind leg of a dog that they later on transplanted after variable periods of detachment from the body and ischemia successfully. Soon, different solutions came into existence, and here are the first descriptions of Collins solution, which is very similar to an intracellular electrolyte composition, and its modification several decades later by the Wisconsin group, which we call now the University of Wisconsin solution, and is the foundation of organ preservation. There are later changes that came, but it is basically a permutation of the same theme, a little bit of this, a little bit of that, but this is the basis of organ preservation as we know it. Although we had very good success with short-term survival, as I showed you, our long-term survival has been pretty much stuck. The red line shows you live donor, and the blue line shows you the deceased donor 10-year survival rate, starting from the 1980s when we had cyclosporin come into the picture. And this is a little hard to interpret because we had a whole lot of things changing at the same time. The patients we transplant are different, the organs we're transplanting are different. Here is the dialysis population. You see that the fastest growing age subgroup is the elderly, especially the ones who are in the 45 to 64 and the 65 and above group. This is reflected in the weight list because you see that, again, the rapidly rising, the one that's kind of greenish, the teal colored, it's 65 to 74 age group, that is still moving up. The rest of them are static, and the young age group, the green line, is going down. So we're having an older and older dialysis and waitlist population who are also waiting for a longer period of time on the wait list. About 50% of patients, the top two dots connected with the short bar, are people who wait for 10 years before getting a transplant. So half of the patients getting transplant wait for about 10 years, and only about 20% or so of patients get kidney transplant before a year. This is all comers, deceased and live donors. And this is reflected again in the age of the dialysis population, the transplant population. We're transplanting older patients, and the younger group, the yellowish color, is going down, and the fastest rising group, again, is the older age group. And we have the largest segment of that transplant populations are diabetic. The organs have changed in that most of the donors are elderly. Here are people who have donated, who have some organ recovered. When you look at the people who have actually transplanted kidneys, it looks like we have younger patients because we're selectively transplanting from younger individuals. But the donors are generally older nowadays as compared to what we had before. So the challenge is to have good outcomes when we are having older and often diabetic patients who we're transplanting with organs from older individuals after waiting for a long time, and with organs that were preserved with techniques that were developed almost half a century ago. And despite all this, transplant outcome has been maintained. And one of the things that we'll be discussing throughout the day is how did you manage to do that, and how we question the existing paradigms to improve outcomes as we move along. And we'll start with what's happening pre-transplant in the first segment, followed by what happens shortly after transplant, and then later on how we manage long-term transplant problems. It is not possible to cover every topic in these areas in one day, so we have a very selected list, which I think represents some of the pressing issues of today. So with that, I will hand over the podium to Dr. Friedman, who would chair this morning segment and introduce our first speaker, Dr. Kasiski. Thank you.
Good morning. We'll now discuss 3 prevalent concerns in preparing for a kidney transplant with experts who've contributed substantially to our understanding of the problem. The first is cardiac evaluation of transplant candidates, because heart disease, as all of us who are in the practice of medicine know, is a common disorder, and as you get older and through adulthood, more and more people have cardiac problems. The first speaker will be Bertram Kaczynski, who is professor of medicine at the University of Minnesota, director of Scientific Registry of Transplant Recipients, and director of Division of Nephrology at Hennepin County Medical Center. His talk is Cardiac Evaluation of Transplant Candidates.
Great. Well, thank you all very much. It's certainly an honor and pleasure to be here and talk on this subject. And first off, I just want to say I have no real financial relationships that are relevant to this presentation. There will be no off-label medication discussion. So the problem I think we're addressing right now is shown in a study that we did. It's actually becoming a little dated now, but I think it's probably no different. We looked at the Medicare claims data at the incidence of acute myocardial infarction and compare that instance with transplant candidates on the waiting list with those who were post-transplant, either deceased donor recipients or living donor recipients. And there's a couple of things I think that's remarkable from this curve. One is that the curves are much flatter after transplant. That is, the rate of acute myocardial infarction is less after transplant compared to being left behind on the waiting list. But then the other thing is this little blip, this perioperative period, in which there's a higher incidence of acute myocardial infarction. So as physicians, it's very tempting to look at this and say, well, gee, isn't there something we can do about reducing the incidence of perioperative myocardial infarctions, and then everything would be much better off. And so I think what most programs have done is some type of evaluation to try to prevent myocardial infarctions after transplant, a pre-transplant screening. And I think this is probably pretty standard, this approach. That is, you start out up there in the left-hand corner of taking high-risk individuals, and this is defined differently. You know, certainly people with diabetes, older age group, maybe cut off of age 50. And if they're not high risk, then you just go on the transplant. If they are high risk, then you consider doing some type of cardiac stress test. If that's negative, then you go on and put them on the waiting list for transplant or do a living donor transplant. If the test is positive, then you go on to a coronary angiogram, and if there are lesions on the angiogram, then you go on to revascularization. If not, then of course you go on to transplantation. Ultimately, if you can revascularize those lesions, then most would consider them to be suitable transplant candidates. If not, then maybe even you don't do the transplant in that individual. What I'm going to argue, though, in the next few minutes is that there's really no evidence supporting this approach, that there's more benefits than harms created by this basic approach. There's basically 2 reasons why you might do screening. The first reason might be to find high-risk patients that you want to restrict from transplant. In other words, you're acting on behalf of your transplant program or the public in general, and not necessarily on behalf of your patient. And this kind of raises interesting ethical questions for us as physicians taking care of those patients. The second reason for screening might be to actually improve the outcomes of those patients. Regarding that first reason, can screening really reliably identify candidates who will not benefit from transplantation. This is a study by John Gill, again looking at Medicare claims data in the OPTN database. And this shows you the net benefit of life years from transplant compared to dialysis, specifically the waiting list. And you can see that, and this isn't even quality adjusted, right? This is just survival and net benefit of survival from transplant. And overall, there's almost a 10-year gain in life expectancy if you're so fortunate to get a transplant. The point of this slide is that this benefit is shared, maybe somewhat lesser, but shared in almost every risk category. That is, patients who have had cardiovascular disease, congestive heart failure, peripheral vascular disease, ischemic heart disease, patients whose end-stage kidney disease is from diabetes. Almost every category you look at of high-risk vascular disease, there's still a net benefit of transplant. And so the question is, are our screening procedures really so good that we can improve on this, or that we should find patients who we shouldn't transplant? And I suspect that that's probably not the case. Showing an even more extreme example is a similar study from Spain, in which they took arguably very high-risk deceased donor kidneys. These were age over 75, and looked at the outcome of transplant using these older deceased donor kidneys. And again, even if there were cardiovascular comorbidities, there still is a substantial benefit from these individuals getting these kidneys and getting transplanted. And that was whether or not they had cardiovascular comorbidities, whether or not they had diabetes. Diabetes is a cause of end-stage renal disease. So again, it's hard to imagine that there's not a benefit, or that we can find a risk population based on our screening procedures that shouldn't get a transplant. So in my opinion anyway, there's really no evidence that screening can reliably identify patients whose outcomes and quality of life would not be better with transplantation compared to dialysis. And certainly screening tests aren't without harms, and they're of course costly and create delays in our evaluation of patients. Now how about the second question? Does revascularization in stable coronary artery disease patients improve outcomes? And here we have to really rely on data from the general population, because unfortunately we don't have the randomized trials and the data really from our pre-transplant evaluation population. So starting out, I'll show you a meta-analysis that was done, again from the general population, of revascularizations versus medical management in individuals from the general population with stable coronary artery disease. Now certainly if you have somebody with unstable angina, then we would all treat those individuals per guidelines, but we're talking about individuals whose coronary artery disease is stable. They may have stable angina and whatnot. So back in 2005, they published this meta-analysis of 11 randomized trials of revascularization versus optimal medical management. And they were small trials. You can see the overall N there is only about 3,000. But basically, overall, with all of these endpoints shown on this slide here, there was really no benefit of preemptive revascularization versus medical management. Now, since this time, there have been a number of other larger, more adequately powered randomized trials. This is the COURAGE trial, in which over 2,000 patients with objective evidence of myocardial ischemia and a significant coronary artery disease, so many of these people had already been screened and found to have coronary artery disease, were randomized to revascularization versus medical management. And the primary outcome was death from any cause and non-fatal myocardial infarction. Follow-up was 4.6 years. And you can see here that there was really no effect on the primary outcome of preemptive intervention with revascularization. Interestingly, a group did a subgroup analysis of these data, and although there weren't a lot of stage 5 CKD patients in this population, they looked at a subgroup of those with estimated GFR of less than 60 versus higher estimated GFRs. There was 320 of these patients in the trial, and there was no difference in the outcomes whether or not you had lower or higher estimated GFR. And that was true for death, myocardial infarction, heart failure events, and whatnot. Another very similar trial was carried out in diabetic patients. And here it was over 1,000 participants. And here the intervention was actually screening and then revascularization versus no screening at all. So more similar to what we do with our cardiac evaluations. And their primary outcome was cardiac death or non-fatal MI. And again, a follow-up was about 4.8 years. And once again, there was absolutely no difference in their primary outcome, whether or not individuals had preemptive screening versus not. A third trial, also in diabetics, type 2 diabetics, over 2,000 individuals with type 2 diabetics and stable coronary disease had revascularization with intensive medical therapy versus just medical therapy alone. Also in this trial, it was a 2x2 factorial design, and they looked at insulin sensitization therapies versus just people on insulin alone. And the primary endpoint here was death and a composite of death, myocardial infarctions, or strokes. And again, this is starting to get a little boring, isn't it? There was no difference in outcomes, so no benefit of preemptive screening and stable coronary disease in these patients. This shows you the survival, and this is freedom from major cardiovascular events in the two groups, revascularization versus medical management. Interestingly, and I think maybe you're aware that the Mayo Clinic group has advocated in our population looking at troponins to create a higher risk group and then to really screen and intervene in transplant candidates who have elevated troponins, while they're on dialysis. And so I thought it was interesting in this particular trial in the general population, they similarly looked at troponins as a subgroup analysis of the trial. And in fact, they found that individuals with higher troponin Ts did have worse outcomes than individuals with lower troponin Ts, not surprising. But they found that this had no impact of whether individuals benefited from the preemptive screening and intervention. So whether or not you had high or low troponins, there still was no improvement in the outcomes. So selecting this high-risk population, again, we're looking at the general population, really didn't select out a population that would benefit from the preemptive intervention. There was one so-called positive style or trial, and this was a trial looking at fractional flow reserve in multivessel disease. And here these, again, were individuals from the general population with stable coronary disease. And they took individuals that had greater than one stenosis with a functionally significant fractional flow reserve and randomized them to revascularization versus medical management. Primary endpoint was a composite of death, MI, or urgent revascularization. And keep in mind that they added this to the primary composite endpoint, the urgent revascularization. Individuals, by the way, that were angiogrammed but didn't have fractional flow reserve deficits were put in another follow-up, a third follow-up group. They called it a registry group. So this study was actually positive in that those with the fractional flow reserve who went on to intervention did better than those with medical therapy. However, this difference was solely due to an increased incidence of subsequent revascularization. Okay, so it's kind of like a reverse lead time bias. In other words, if you already had revascularization, maybe you were less likely to have revascularization in the immediate future. And in fact, if you look at the rest of the endpoints, that is death from any cause, no different. Myocardial infarction was also no different. And so this has been a hotly debated trial, whether this should really be considered a positive result. Did they really improve outcomes in these patients or not? And then finally, there's a trial that looked at screening before major vascular non-cardiac surgery. And this was the CARP trial, Ed McFall's group in the Veterans Administration. They took individuals who were screened out and had coronary artery disease on angiogram before major surgery. And these were planned surgeries, like AAAs, peripheral revascularization and whatnot surgeries. And they ended up with 510 who had coronary artery disease and lesions that could be revascularized, and they randomized them to revascularization or not prior to these high-risk surgeries. And so guess what? The outcomes were really no different. In fact, if anything, the outcomes were a little worse in the group that they was preemptively revascularized because they had delays in surgery, increased costs, and whatnot. And so that group concluded that doing this preemptive intervention before surgery was really not beneficial. So this summarizes those trials, basically. And again, you can see that they're all pretty much negative in the general population, that doing preemptive screening and preemptive intervention to try to improve patient outcomes is probably really not helpful. The only positive study being that fractional flow reserve study. And again, that only part of that outcome that was improved was having to have fewer procedures in the future. So what is the evidence that screening and revascularization before kidney transplant improves outcomes? And well, there's one randomized trial, okay, and this was published back in 1992, Connie Mansky, University of Minnesota, in diabetic patients. And the trial was stopped after only 26 patients were randomized, 13 in each arm. And if you look at the event rate in the group that was medically treated, it's astronomical. I mean, no one has a 90% event rate for vascular disease or myocardial disease. So I think most of us think that the study probably shouldn't have been stopped early. And in any case, it's probably history, and the patients really aren't treated anymore like they were treated back in those days. And so not really very helpful evidence to elucidate the question. We can ask, what is the yield of all of the screening that's done? Because there's a number of studies that have looked at that. And in other words, of all the screening that we do, how many individuals as part of their pre-transplant workup end up with revascularization? Because if they don't get revascularization, then how could possibly the screening benefit them? And it turns out it's probably, you can see all these studies up here, probably less than 10% who we subject through this screening procedure end up to go on to have revascularization. So not a very high yield for the procedure. So, I advocated with the NIH for a number of years that we needed a randomized trial. We did a pilot, and it turned out fine and everything, but ultimately they balked on doing the trial and as being too expensive and whatnot. But we are lucky that globally now there is a randomized trial that might help us answer this question. It's called the ischemia trial, and a component of the ischemia trial is in CKD patients. Specifically, they're taking 1,000 individuals, randomizing 1,000 individuals who have moderate ischemia on stress imaging and a GFR less than 30 or on dialysis. And I understand that actually most of these patients are being screened because of their workup for transplantation. And then they're randomizing them to invasive strategy with revascularization and optimal medical therapy plus just optimal medical therapy alone. And the average follow-up is going to be 4 years, and the primary endpoint is going to be a composite of death and myocardial infarction. And it looks like they're getting there. So recently I went to their website, and they've now enrolled 662 patients in the ischemia CKD trial. And their goal, again, is 1,000. But it looked like they're pretty much on target. So let's keep our fingers crossed that they'll get adequate enrollment, and we'll at least see in this population whether the strategy is beneficial or not. Okay, so just a little footnote here on what else we should be doing with our patients. If not screening, then what can we do to prevent vascular disease events? Certainly, I think most of us would agree that smoking abstinence, if we can achieve it in our patients, would be a good idea. Continuing a statin if they're high risk for ischemic heart disease, and that's probably most of our transplant recipients, and there are good guidelines to govern that. A little more controversial are beta blockers, but still guidelines are suggesting that if patients are on a beta blocker, that you should probably continue the beta blocker in the perioperative period. Probably continue aspirin prophylaxis, also a no-brainer. And then there are some guidelines about how we handle people that have had revascularization, particularly with coronary stents. And in general, the recommendation is to delay surgery for maybe 30 days after a bare metal stent placement. And a little less is known about how long to delay surgery after a drug-eluting stent. But the party line is generally at least 3 months, maybe 6 months if you can delay surgery. And probably the other question is whether you stop or continue the dual antiplatelet therapy that goes along with stent placement. And this is still a lot of debate in this area. I'll just show you a slide from the ACC-AHA guidelines. And again, this is in the general population. Recommending delaying non-cardiac surgery for 30 days after bare metal stent placement, ideally 6 months after drug-eluting stent. And they say there's really no clear association between antiplatelet strategy and rates of perioperative major adverse cardiac events and bleeding, and that we really need adequately powered randomized studies to know how to handle this dual antiplatelet therapy question. So in summary, I think screening is unlikely to identify patients who will really not benefit from transplant, because so many of our patients do indeed benefit from transplant. I think there's really no evidence that routine preoperative screening improves outcomes, and we really do need the randomized trial, and hopefully the ischemia CKD trial will cast some light on this. And in the meantime, we should encourage smoking abstinence, continue therapies like statins, beta blockers, and aspirin, and consider delaying surgery if there's been a recent stent placement. And again, this question of dual antiplatelet therapy, what to do with that in the perioperative period. And so I think I'll stop here and thank you very much. And I think the strategy is that there'll be a panel discussion, or take questions now or later. Okay.
Next, we have the chief of Downstate's Department of Surgery, who is involved with organ transplantation and donor protection and the outcome. And that's Dr. Devon John, who will consider with you the problems that come up in protecting the donor as the transplant operation procedure, from selection of the donor, testing the donor, and then the outcome in the donor progresses. Dr. John.
Good morning. Thank you very much. Good to see some old friends and meet some new people. Dr. Ted asked me to give a very broad discussion on donor management, organ preservation. So this is going to be very, very basic because it's just such a broad topic, because in each one of these I could spend many hours talking about all kinds of things. And it's more of an awareness issue in terms of what goes on prior to the transplantation process and what do we think about as transplant professionals. So a brief review. We know in the last few years there's been a significant increase, last 5 years, significant increase in organ transplantation around the country, and this is the US data showing about 20% increase. And with that, we can see the number of deceased donor organs that are transplanted, over 27,000. The number of donors, 9,900 plus. And the rates of donors per million population is 28.5, which is an increase in recent years. And you can see the living donor population as well as the living donor organs which are transplanted. Some of the living donors were dual organ donors. In any case, again, despite the number of people listed, we certainly cannot meet the demands, and this is nothing new. So what do we do when we go out and we identify a donor for potential organs, and what do we have to think about, and what choices do we make? The primary responsibility as transplant professionals is to recover the viable organs for transplantation, and which requires optimal medical management before and after death is determined, and despite the source of the organ, whether it's a brain dead donor or donor by cardiac arrest. And where do we typically encounter these donors? In the classic places, the emergency room, the ICUs, the operating rooms, or when EMS brings them in. And the typical cause of death for these donors were anoxia, which comes in many forms, whether it's stroking or an MI, drowning, intoxication, and poisoning. And when I say intoxication and poisoning, this includes the opiate problems that we're having right now, which accounts for a significant number of the donors that we do now. Head trauma, 33% from motor vehicle accidents, falls, the most common. Gunshot wounds, particularly in New York, are way down. It used to be back in the day, back in the 80s and 90s, when we really were fairly busy because of that. Strokes account for 31%. Tumors, CNS tumors for a small amount, and others for another 2.6. Now, when I was talking to my residents about this whole process of how do we define who the donors are and where they are, there's always a bit of confusion who these donors are, and they wanted give a brief discussion, the idea of what's a brain dead donor versus a donor by cardiac arrest or DCD donor. And these are some of the key distinctions and how it comes about. And in 1981, the Uniform Determination of Death Act, this was discussed repeatedly for many years. How do we find brain death? And you can see the criteria which are listed here as part of the regulation or law, if you wish. It's irreversible cessation of circulatory and respiratory function, irreversible cessation of all functions of the entire brain, including the brain stem. Therefore, that is defined as death. And to determine that death must go accordance to what's accepted medical standards in your area. So the prerequisite in terms of this, which allows us to define what brain death is, must include, we look at a particular checklist, and that is we must define what the proximate cause of death is. With the proximal cause of death, we have to look at what the cause of. We have to identify a particular cause, whether it's trauma or intracranial bleed and such. Identify, by imaging studies with CT or MR studies to help us confirm the diagnosis. Exclude all possible confounding criteria, such as medications, or if someone is cold below 90 degrees Fahrenheit or 32 degrees Celsius. And once you exclude these criteria, then you can define brain death. There's a series of tests, clinical studies, such as absence of pupillary light reflex, corneal reflex, absence of any kind of reflex within the face or maxillary region, absence of doll's eyes, and absence of ocular vestibular reflex, which are we call cold calorics by putting water within the cold water in the air to look for nystagmus and slow response, as well as the gag reflex in the absence of these. So these are the clinical criteria in which we use to make that determination. Next part of it is which we all use, is that the apnea test. And this is where we hyperventilate a patient, make sure they meet all prerequisites. They're normothermic, hemodynamically stable, with limited presses of such, no sedation, no paralytics. Make sure they're well oxygenated, hyperventilation, and make sure the partial pressure of CO2 is close to normal as possible. We disconnect the ventilator while insufflating some oxygen, and observe for any ventilatory movements such as respirations. And a positive test where there's no respirations is an increase in the PEA CO2 to 60 or 20 millimeters above for those who have elevated PEA CO2. And certification of brain death with this is associated with a neurological exam that confirms this. In many areas around the country, a single test is appropriate. For apnea, some areas require 2 tests. In New York, you can see what our practice is, a single test with at least 1 supported neurological exam. Many hospital systems require 2 neurological exams, oftentimes 24 hours apart. It has been reduced now. Some hospital systems go with 4 hours apart or just for a single exam. Okay, particularly if the donor is unstable. The other studies which we add to the process, imaging studies such as a 4-vessel angiogram which is considered the gold standard for cerebral blood flow. Whether we need this or not is not necessary, but however, it is definitely confirmatory. In the absence of flow above the bifurcation, carotid bifurcation over vertebral arteries is confirmatory. Some CT angiogram also confirms this. Transcranial Doppler, which can be done in the ICU, looking for the presence of lack of forward flow, lack of forward flow, also confirms that. There's also nuclear studies, technetium scans, looking for lack of perfusion within the brain, and EEGs, which is very, very unreliable because it can often be variable with sedation or hypothermia or just the background electrical activity within an ICU. So, but the bottom line is, despite all of this, okay, the key way in which we determine brain death is a clinical process, a good neurological exam and apnea testing. Okay. Donation after cardiac death, that's a new criteria, which the federal government wants us to do. About 18% of all our donors to be donors by cardiac death. There are consequences to that law, unintended consequences. And these were individuals who have suffered catastrophic, non-reversible neurological injuries, whether traumatic or non-traumatic. Oftentimes, they actually are in a vegetative state, very well supported pharmacologically or mechanically, and usually in ICU or some sort of monitored setting. Often, when the donors are approached or possibilities or the families for possibilities of organ donations, usually if there's an advance directive in terms of to withdraw care, or the family decides to withdraw supportive care at this point in time. I put this slide up here, and this is from our local organ donor network, and the process of consent. Keep in mind, once we have donors, we have to look at them very carefully, and we have to recognize that the family is a very important part of the supportive environment, or whoever their supports are a part of the process of the organ donor process. And we cannot isolate them, and oftentimes this is a very difficult time in people's lives that they undergo the process of grieving for a loved one who is defined as being brain dead or is in a vegetative state, and where withdrawal of care is being considered. And therefore, there's got to be a significant support mechanism to make this work, and where we go out and discuss this with the family, discuss the confirmatory tests, ensure that the family really understands what's going on, and then request make a request or consent for donation. And I can tell you this is very difficult. New York is a difficult area to get this. Our consent rate is much lower than the national average. This is something that we contend with on a regular basis. Now, once we define a potential donor, what do? How do we manage these donors? And what's key? Okay, I put in red down here, don't ignore the potential donor. And this is one of the big problems that happen within our medical community. Once someone's defined as brain dead by neurological criteria or otherwise, oftentimes we sort of like ignore that potential donor and pay attention to those who are living. And what's key to this, that we must manage the donor with the same intensity as if they were alive, and which requires whatever invasive techniques, IV fluids, inotropes as such. That's a key thing in this entire process. So the typical things we typically do for anyone who's a potential patient, that we manage history and physical, and what's key to this process is the social history, because that tells us a lot of information about the past and the relative risk associated with the organs that are to be transplanted. Okay, you typically monitor vital signs, such IV fluids and film pressures. Nursing care is important, particularly with ventilators and everything that's associated with the potential donor, any tubes, drains as such. And we add artificial chairs, particularly when you talk about tissue donors, cornea donors and such. We send out a standard set of lab data, which is a CBC, should be basic metabolic profile there, or comprehensive metabolic profile, coagulation profile, blood gases, blood types, which are critical and required, at least 2. HLA type-in, which for tissue typing is critical for us in terms of the transplant process, and all the other labs. Serologies, these are done by serological testing as well as nucleic acid testing, CMV, EBV, toxo, HIV, Hep C, B, West Nile virus, depends on the season where you are, syphilis and otherwise, and typically culture the donor. We typically do imaging studies when we look at specific organ structures, chest x-rays for all donors, echocardiograms for looking at cardiac donors, sonograms looking at the liver and kidneys, particularly for those donors. CT scans oftentimes are done in the traumatic patients to look at and you can look at the organs review for any injury patterns, bronchoscopies for lung donors to see if there's any significant inflammation as such. Cardiac catheterizations are oftentimes requested from the cardiac community, particularly on a marginal donor, particularly a middle-aged or older donor, and liver biopsies sometimes requested by the liver transplant community. So what happens to the donor? There are a lot of physiological changes in the brain-dead donor. You can see we look specifically cardiovascular, respiratory, and endocrine, and fluid and electrolytes. What happens? With brain-dead donors or donors with particularly intracranial injuries and or close to brain death, we have the typical cushion reflex. One, a reflex hypertension and bradycardia, which is often which is followed by intense vasoconstriction, tachycardia, which results in depletion of catecholamines, vasodilatation, hypotension, and all these things can lead to organ failure and eventual the demise of the donor. So the lungs themselves are prone to pulmonary edema because of this, the injury patterns, as well as recessive efforts. Oftentimes we overload the donors or the patient. The injury from an inflammatory response results in endothelial injury and inability to use the lungs themselves. So the endocrine system and responses to the body during brain death. We lose the posterior pituitary function very early, which encourages diabetes insipidus, polyuria, and hypernatremia, which is critical. And we manage with fluid replacements appropriately, and arginine, vasopressin, or desmopressin, which is critical to the process. Thyroid hormone decreases. You have a sick euthyrized thyroid state, and T3 and T4 are oftentimes in use, and which has improved organ outcomes when you deal with multi-organ donors. We also get changes in hyperglycemia in terms of insulin metabolism and glucose metabolism, and this can affect kidney outcome in some cases. temperature regulation is critical. The hypothalamus is affected, hypothermia, and the inability to shiver in these patients results in vasodilatation, a decrease in metabolic rate, an increase in acidosis, coagulopathy, arrhythmias, and like. So we monitor and maintain that. So how do we do this? It's a rule of 100. Okay, we want to target the systolic blood pressure to about 100 or better, urine output to about 100 cc's per hour or better, which is not often achieved, or sometimes achieved. The PaO2 greater than 100 or better, 100 or better. Target the glucose to maintain within a normal range, and hemoglobin about 10 or greater. And all these are to mitigate the changes that occur during brain death. So, keeping the core temperature greater than 35 is prior to organ donation is critical. We talked about that. Fluid management comes next, and this is one of the key things. Because of polyuria, dehydration, and vasodilatation, central volume depletion, what do we typically use? Typical crystalloids, ring is lactate, plasmolite, whatever you choose. We do not encourage, a matter of fact, it's contraindicated to use the starches, oftentimes used in the operating room by the department of anesthesia because it can damage the kidney itself, the epithelial cells, and result in graft dysfunction. And to use, again, to emphasize arginine, vasopressin, desmopressin for the diabetes insipidus patients. Okay, hypernatremia is critical. We need to monitor that. From the kidney perspective, doesn't matter so much for us, but in the liver transplant recipients, hypernatremia, excess of like 150, 157, can result at the time of reperfusion, at the time of transplant, in terms of cell injury and hepatic graft loss or dysfunction of the liver itself. We, again, fluid loading doesn't really affect the kidney, but it can affect the heart patient, the heart donor, and the lung donor. Be careful about that. And the idea is to maintain the appropriate hemoglobin, hematocrit levels to maintain the patient the donor as best we can to improve tissue oxygenation. Presses are oftentimes used. Dopamine is often the first line choice, but anything is possible, epinephrine, norepinephrine, whatever works to improve the functional capacity of the donor, at least at the tissue level, to prevent ischemia and shock, okay? And the whole ventilatory management is about the injured lung, okay? That is low tidal volume, okay? Low peak area pressures, the lowest FiO2, and optimal PEEP as possible, and try and maintain fluids as best you can to reduce lung injury. So all of this is sort of like in this very busy slide, and I'll move on. Electrolytes. Hypernatremia we spoke about, sodium greater than 150, we correct that, fix polyuria if it occurs, hydrate appropriately, and reduce the sodium as best we can. If it goes below 133, we also correct that with normal saline infusion. Hyperkalemia and hypokalemia both correct. As chloride and bicarb, we rarely ever do anything about. Magnesium, if it's particularly low, we correct, and phosphorus, same thing, as well as, and if you have hypocalcemia. Okay. Other things, vasopressin, we talked about that before in terms of diabetes insipidus, but also helps maintain blood pressure and cardiac output. In case of adrenal insufficiency, which is common, methylprednisolone, steroids we add, infuse insulin as necessary, particularly in cases of hyperglycemia. And T3 and T4, we talked about that in terms of improving the hemodynamics, particularly in the multi-organ donor. Other things we look at, we pan culture. Remember, bacteremia and fungemia is not a contraindication, but when you have viral agents, HIV, herpetic viruses, particularly in encephalitic patients, West Nile virus, which we've had experience here in New York with that, we do not use it. We do not use these organs. Hep C is possible because of the current medications and treatment plans. People are using Hep C organs, which is fine. Hep B, surface antibody positive. This is program dependent. There's some programs that will use it, depends on who the recipient is. And it's pretty aggressive. break for the next phase. Think about it. I wouldn't mind being there right now. Okay. So once we've gone through that, we procure the organ. I guess that's the procurement phase. I'm procuring an organ right here while fishing, or procuring something. We go and do the organ removal process. Once we remove it, what do we do next? And this is where preservation comes into place, okay, and it's critical. We have to remove the organ, okay, when removal of the organ and storage for transplantation. This alters the hemostasis and ventral function. The issue is injury. It's a result of ischemia or hyperthermia, and ischemia either as cold ischemia or warm ischemia. And the whole idea of preservation is to minimize damage and promote organ survival and function. Okay. The warm ischemic phase is which, particularly in the donor by cardiac death, or DCD, it's more likely than brain death, because during the brain death, we cross-clamp the aorta or arrest circulation at the same time we infuse cold preservation solution. So the warm ischemia is defined as the time from interruption of circulation or reduction of circulation to perfusion of the organ with cold preservation or hypothermic solution. And the cold ischemic phase is during the time when the organ is sitting in some sort of ice or cold preservation solution prior to transplantation. So the whole issue of injury in this case and what happens. The idea is to maintain the integrity of the cell and prevent it from being injured. Ischemia and hypothermia results in a lot of changes along the cellular membrane, where you change the permeability of it, and which may result in changes in intercellular environment. And this can result in cellular swelling, fractured membranes, organ dysfunction, mitochondrial injury, which is a key part of the whole process. Remember that the organ itself, during this cold preservation, during this non-perfused state, is undergoing anaerobic metabolism, which can result in significant acidosis and a release of free radicals, oxygenated free radicals, cytokines, and nitric oxide. So what do we do to mitigate these factors which can result in cellular death and organ dysfunction? The key thing, like we put food in the refrigerator or in the freezer, is hypothermia, which reduces metabolic activity, reduces the cell energy requirements, and therefore the ATP needs, reduces how do we prevent cell swelling by creating a hyperosmolar solution with low sodium, which represents more the intercellular milieu or the contents of the cell rather than the extracellular, which is hypernatremic or have higher sodiums, limit the cold ischemic time, and prevent reperfusion injury with free radical scavengers. So over the years, we've come with all kinds of things. Dr. Tedler showed a slide of urocolins. It's one of the first preservation solutions. Others have come in the market over the years: Ross Marshall, citrate solutions, HTK, phosphate buffer solutions, University of Wisconsin, and Celsius. The most common ones which are used are HTK and University of Wisconsin. University of Wisconsin definitely is probably the most common used in the United States at this point in time. And to go through it, you can see what the composition is. Okay, and you can see I'm not going to go through all of it, but the key thing is to maintain a normal pH, a low sodium, high potassium, and a hyperosmolar circumstances with the free radical scavengers and the like. Okay, and you can see that with osmotic active agents, which prevent cell swelling, electrolytes, which exert an osmotic effect, depends on where you place it. The hydrogen ion buffers to reduce the acidosis, or colloids, which we add to help flush the organs, metabolic inhibitors, metabolites, and antioxidants for free radical scavengers. All these are part of the contents of the preservation solution. So what does this mean? So what does that give us? It gives us time before we operate. And what's ideal and what actually occurs are two different things. Because we get organs that travel across the country, how far can we push the organs, and on what can we do? Most of us like the ideal. Put a kidney in before 24 hours, or liver before 12 hours, or pancreas between 12 to 18 hours, or even less than all the above. How far has it been pushed? These are some numbers that have been pushed. They've been pushed more than that. Depends on your circumstances, how willing a potential surgeon or transplant program are willing to push the limits. With each time you push the limits, you increase the risk of organ dysfunction or failure. And more recently, or at least this is not a more recent, this idea of cold storage. There's cold storage, just meaning that it's static storage with placing the organ in a preservation solution itself, or in some cases, more with kidneys than any other organ, though there's been recent work with lungs and with livers, pulsatile perfusion pumps with cold preservation solution. This is commonly used within this area and has shown to have some significant improvements, particularly with the marginal organs. Looking at pump versus static perfusion, you can see, looking at a randomized study that was published back in 2009, looking at 336 on pump and cold preservation solution, you can see that the delay graft function on the pump was less than that of the in cold storage. 1-year survivors were better, and primary non-function are about the same, though a trend towards the pump. The New York area has been using that particular pump, I think, for about 10 years now. There are other pumps on the market. And if you're curious to take a look at it, it's in the Museum of Modern Art as a design for sort of a representation of medical design. I thought it was pretty interesting. So, what's our issue? Okay, long cold ischemic time causes delayed graft function, so we try to avoid that. Whether something has been stored for a long period of time in for long cold ischemic time doesn't necessarily mean you discard the kidney. You have to look at the circumstances. You have young kidneys, you can push them out further. They're particularly harmful for the extended criteria donor or the donor by cardiac death, though many of us have pushed this out to as much as 50 hours and have had good outcomes. Delayed graft function is associated with increased acute rejection, and cold ischemic time and delayed graft function have little influence on late graft function and long-term survival. So what's the future outlook in this process? Okay. More recently, there's been some studies. There have been some animal models and looking at normothermic oxygenated and nutrient-based perfusion. Studies have been done particularly in the liver because the kidney can tolerate long cold ischemia and can be transported across the country pretty well. The thinking about this is that, one, you can broaden the region of organ distribution, which is a contentious process in this country in terms of organ allocation. However, there has been some evidence that shows that in these environments, you may be able to sort of like help recover whatever injury pattern the liver may undergo, though it hasn't been proven in human studies yet. All these have been done in animal studies. These concepts may be extrapolated to kidneys, particularly in the older or the extended criteria donors, where we may give it a chance to recover from sort of like an ATN profile, maybe not. We're not sure. In any case, so in summary, donor management, the whole idea is to maximize a precious resource. Take care of the donor. Each organ system has specific requirements. Understand the brain death and cardiac death criteria, and recognize the needs of the family. In terms of preservation, the idea is to limit cellular injury, which can limit organ injury and improve organ function and patient survival. The idea is to preserve function. Time is of essence. We're critical about this. Limit the amount of time between procurement and transplantation. And there's clearly a need for further research in this area to reduce and improve outcomes. Reduce injury and improve outcomes. Thank you.
Our third presentation in this session is from a neighbor, not far away, a subway ride to Columbia University. Dr. Elizabeth Verna will be considering the indolent problem of potential recipients who are infected with hepatitis C and D, or D, not both. And what we should do or not do in handling these patients to get optimal patient survival. And it's a pleasure. Dr. Verna is Assistant Professor of Medicine at Columbia, and she's Director of Clinical Research, Transplant Initiatives, and the Program Director of Transplant Hepatology Fellowships at the Center for Liver Disease and Transplantation at Columbia University College of Physicians and Surgeons. We welcome you to Brooklyn. I'm glad you found the subways manageable, and we'll hear from you about the problem that's indolent and really nationally pervasive, and that is, what do you do with a patient who has the virus, is living with it, but needs a transplanted organ? Welcome to Brooklyn.
Thank you very much for that introduction. I actually live in Brooklyn, so it was a pleasure to get up this morning and not commute all the way into northern Manhattan. How that happened is a story for another time. So I'm excited today to talk about viral hepatitis and transplant recipients, in particular kidney transplant recipients. I'm going to spend most of the time talking about hepatitis C because I think that's where the most activity is and the most opportunity to update everybody. But there's a few things I want to say about hepatitis B at the end of the talk. And I really think this is sort of a crucial moment in our understanding of how to manage hepatitis C in transplant candidates and recipients, and sort of a rapidly moving field. So we'll go over a little bit about what we know at the moment and sort of then where things are headed. I'm going to talk also about viral hepatitis mainly in the recipient, but also a little bit about viral hepatitis in the donors, because it's sort of another hot topic that's for discussion these days. So I have no financial disclosures. I will be discussing off-label use of medications for both hepatitis C and hepatitis B. So I'm going to start off by saying viral hepatitis is really very common. About 1 in 12 people around the world have viral hepatitis, which is just a shocking number. And in general, it's a little bit lower in the United States, but it's still very common. Both hepatitis B and hepatitis C are more common than HIV in the United States, although I think they get a little bit less press. And the real problem is that the majority of people that have these viruses don't know it. So as you're probably aware, there's new CDC screening guidelines to try to address this, but it really is an epidemic, especially for hepatitis C in the United States. And as bad as it is for the general population, hepatitis C is clearly overrepresented in patients on dialysis and with advanced CKD. And the data on this are all over the place depending upon the population that you're studying and their individual risk factors, but I think it's clearly true. So if about 2% of adults in the United States have hepatitis C, if you look at across the different regions of the world here, anywhere from 3 to up to 60-something% of people with advanced CKD have hepatitis C. So it really is considerably overrepresented, and this includes in the United States, where meta-analyses show the rate is about 14-15% of the dialysis population. And you can see, though, that this is a large study where they looked at multiple dialysis centers across different countries in the United States as well as Europe and parts of Asia. We can see the overall mean prevalence in the dialysis population was about 13.5%. But in fact, there were many centers that had rates of less than 5%, and then some that went up all the way to above 50%. So it depends, again, a lot on your underlying population and their risk factors coming into the dialysis center. So why is it so overrepresented in dialysis patients? And I think it's two problems. One is that hepatitis C has been known to cause chronic kidney disease. And then the flip side is that probably patients with advanced CKD, especially on dialysis, are at higher risk of acquiring hepatitis C. And you probably know more about this than I do in some respects, but there's a lot of epidemiologic data to suggest that hepatitis C is associated with proteinuria and abnormal kidney function as measured by creatinine in sort of large epidemiologic data sets, including NHANES and others. And in terms of why this might be, it's now pretty clear that hepatitis C causes various forms of chronic glomerular disease. And this has been known for some time. It's associated with multiple different types of diagnosis in this setting. And in fact, there's some data that in some circumstances, treatment of the virus and clearance can actually reverse profound proteinuria and some of the pathology in the glomerulus that we can see on biopsy. In addition, there's pretty good data that prolonged time on dialysis is also a risk factor for acquisition of hepatitis C. And certainly, at least in my practice, I have a number of patients who became positive while on dialysis when they were clearly screened negative when they started. And in large data sets overall, in general, the risk factors for hepatitis C positivity among dialysis patients includes the number of blood transfusions they've had, how long they've had end-stage renal disease, their mode of dialysis, with hemodialysis being more common than peritoneal dialysis, the prevalence of hepatitis C in their own dialysis unit, also male gender, and a history of IV drug use. So in general, these again are risk factors for transmission that are incredibly common among patients with end-stage renal disease on dialysis. So as a result of this, there are pretty clear guidelines trying to inform everybody about how to test and screen for hepatitis C among dialysis patients. And I think it's possible that not everybody is totally adherent to these guidelines, especially the idea that some patients actually need NAT testing or RNA testing and not just antibody screening. But the guidelines as they're stated now, and I understand they're going through updating these guidelines, but as they're stated now, is that everybody on dialysis should be screened for hepatitis C every 6 to 12 months. And in low prevalence setting, usually that's just an antibody or a serology. And if the patient has normal liver tests and a negative serology, then we don't need additional testing. One important thing to note is that a patient with a negative serology but chronically elevated AST or ALT is going to require more testing, including either a NAT test or an RNA, because there is a certain percentage of patients that lose their antibody over time. In high prevalence settings, and how to define that I think is a little bit of debate, but certainly we all have dialysis units in New York City that we would probably classify as high prevalence settings, they actually recommend going directly to the NAT or RNA testing. And again, this should be done every 6 to 12 months to capture transmission. So this is sort of before we get to transplant, but it's obviously an important part of the screening procedures for transplant evaluation as well. But this is sort of our baseline population. So why is it important to identify patients with hepatitis C? And I think in the general population, it's very clear that treatment of hepatitis C decreases all-cause mortality. So this is the general population. This is VA data. There's lots of other studies that have shown this as well. It's not just liver-related mortality, but it's all-cause mortality related also to cardiovascular disease, different forms of malignancies, renal failure, lots of other extrahepatic manifestations of hepatitis C. It's also clear that hepatitis C infection predicts mortality among patients who are on dialysis and have advanced CKD. There's lots of data to support this. I just put one example here, which was a meta-analysis of 4 studies with over 2,000 patients, which basically showed an increased pooled relative risk of mortality. And this was largely attributed to liver disease and HCC, but it's also all-cause mortality as well. So this is very important because depending on which center you're at, anywhere from 10 to up to 50% of the patients waiting on the kidney transplant list are hepatitis C antibody positive. And so because this portends a poor prognosis while they're on the wait list, you have to learn how to either treat the hepatitis C or get them transplanted and treated to improve their outcomes. It's clear that untreated hepatitis C, when the kidney transplant occurs, leads to decreased graft survival after the transplant. Some of this is because of de novo glomerular disease in the graft after the transplant, and also other sort of less specific conditions, including things like persistent proteinuria and acute and chronic transplant glomerulopathy. But all of those things are increased among patients that continue to be viremic after the transplant. And there's also a number of meta-analyses showing the increased risk of graft loss and death compared to hep C negative transplant recipients. Some of this is also probably due to increased rates of other complications and comorbidities, including, most importantly, diabetes. But I think that this is also due to liver disease and progressive liver disease in an era where we didn't know how to treat hepatitis before and after kidney transplant. However, a key point, and I think the reason why even before the new era of hep C therapy, we continued to do these transplants, is that survival is clearly better with a kidney transplant than waiting on the wait list on dialysis, even among even among hep C positive recipients. So similar to the general population, there is a huge benefit to transplant over dialysis, but in general, their post-transplant outcomes are a little bit inferior to their hep C negative counterparts. So that's sort of the historical perspective, and I really think things have changed dramatically because of the availability now of safe and effective hepatitis C treatment. And how this is going to play out in terms of how much it improves outcomes for these patients, I think is not yet fully in the literature, but it's coming. And the reason for this is that we now have hepatitis C therapies that are effective in more than 95% of people in the general population. And now, in addition, we have therapies that are effective also in special populations, including patients on dialysis and including post-transplant, despite all of the negative predictors that you would think would go into that therapy. And so now it's not a question of whether we can cure patients with end-stage renal disease before or after transplant, but the question is, what is the optimal approach for an individual patient? I'm not going to get too specific about all the different classes of medications because I think it's not too useful. I'll show you the data for the currently recommended regimens before and after transplant just among this special population. But there are a few things, sort of key themes about the currently available meds that I thought would be useful. So right now there's 4 classes of medications that are approved. Some of them have many representatives and some of them only one. And each of these classes has some important specific characteristics that sort of hold true usually throughout the class. One of the most important things is that sofosbuvir, which is by itself here, let's see if I can, the center column there, is really the backbone for most regimens that are currently approved. Sofosbuvir in many ways has very positive characteristics because it's fully pangenotypic, meaning it treats types 1 through 6 hepatitis C. It has a very high barrier to resistance and has a very low potential for drug-drug interactions and almost no side effects. So in some ways, this is the ideal hepatitis C drug because it can be used to treat almost everybody, including decompensated cirrhosis after transplant with minimal drug-drug interactions. The Achilles heel of sofosbuvir, which is important for this population, is that it's completely renally metabolized. And so at the moment, it's actually contraindicated for patients with a GFR under 30 and on dialysis. I'll talk about a little bit more of that later about how that's perhaps controversial. But what that means is that basically all of the regimens that contain sofosbuvir are not the regimens that are going to be used in patients on dialysis, at least in their FDA label. Hepatitis C therapy is a very rapidly moving field, and I just put this up because even I refer to this all the time. I'm actually on this guidelines committee, and I still have to read through this sometimes. This is a very simple website to remember, hcvguidelines.org, and this is basically guidance that's endorsed by the AASLD, which is our liver society, as well as IDSA, the Infectious Disease Society. And it's constantly updated, even based upon abstracts and things that are presented at meetings. And if you look at the top bar there, you can actually click on unique treatment populations, and it gives you a section just on renal impairment or kidney transplantation for updated guidelines on how to treat those specific patients. So this is great because it not only gives you sort of the guidance and recommendations, but it gives you references and summaries of the literature that was used to support that recommendation. So if you ever have any questions or even want to direct patients to this site, I think it's very useful. So what medications have been tested in patients with end-stage renal disease? And at the moment, there's basically 2 regimens that are sort of endorsed for use in this setting. The first one is grazoprevir and elbasvir, which is Zepatier, which probably many of you know. This was the first one to be FDA approved for use in patients with advanced kidney disease, either stage 4 or 5. And this was the main study that brought this to the market. So this was actually over 200 patients. Importantly, this was only genotype 1. So this is a regimen that really only applies to genotype 1 patients, which is a problem for many of the other patients that we see. Patients were randomized to 12 weeks of therapy or delayed therapy in order to look at toxicities possibly associated with the regimen, but everyone was treated ultimately. 6% of patients were cirrhotic, 3/4 of the patients were on dialysis. And you can see here the overall response rates. So in the whole set of patients, 94% of patients were cured. All of the patients with cirrhosis were cured. 99% of patients on dialysis were cured. So these are response rates, that back in the interferon era, we would have thought were a miracle when we were curing probably about 1/4 of patients. And this is sort of too small for you to look at in particular, but I put this up here to show that they were very worried about toxicities of these regimens, especially in patients with significant comorbidities, but really did not see any significant differences between the patients that were treated right away and those that were deferred. And they, in particular, honed in on the renal outcomes, and all the text on the right side of the slide sort of summarizes those findings. And basically, there was no significant difference in terms of patients that ended up having to go on to dialysis or changes in GFR among patients that were not yet on dialysis. So this was the first regimen that was approved for patients on dialysis with Hep C. The other regimen that doesn't yet have this in its label, but is a regimen that can be prescribed and has some data available and is also endorsed in the AASLD guidelines, is what I'm going to call GP. So this is a regimen that was just approved in the last couple months. It's great for just run-of-the-mill chronic hepatitis C. It also, in the label, can be used for patients that have previously failed other combinations of oral medications, which is an important hole that they filled. And importantly, this regimen is fully pan-genotypic. Okay, so it's not just genotype 1. This is a regimen that can be used for all the other genotypes as well. This first initial study was a single-arm study that's only been presented in abstract form so far, where they used the regimen for 12 weeks, and 82% of the patients were on dialysis. A full 20% were cirrhotic, and they basically found a 98% cure rate. And if you look at the patients that failed treatment, they weren't actually virologic failures. They were patients that were discontinued or lost to follow-up. They actually had no breakthrough or relapse with this regimen in this population. And in terms of safety, similar to the other study, overall it was very safe. The one thing that I'll say that I've seen clinically in using this medication in patients with renal failure is that there's a pretty significant incidence of pruritus. So it's about 20% in patients on dialysis. It's less than 5% of patients not on dialysis with this regimen, but usually it's minor. There is a small incidence of actually cholestasis or elevated bilirubin in these patients, so they need to be monitored for that. But if it's just pruritus without that, usually we continue the treatment regimen. There's a larger trial that's that's ongoing that actually we just closed for enrollment with this regimen in dialysis patients, so we should have more data on this soon. So what are the current recommendations if you're going to treat before transplant in patients with advanced CKD? So if you have a GFR over 30, you can go ahead and treat as though you had a normal kidney function. So basically all of these medications, which are the approved combinations, don't need to be dose adjusted or considered in any way if your GFR is above 30. For patients with GFR less than 30, there's basically those two recommended regimens. And again, important difference between the two of them is which one is pan-genotypic, which is the GP regimen, versus basically just for genotype 1 and 4, which is elbasvir and grazoprevir. But really, both of them are highly efficacious in this population. So if you're going to treat patients on dialysis, we have great efficacy. Sofosbuvir, which we touched on briefly, which is contraindicated in patients with GFR less than 30, this is really because it's almost exclusively eliminated by the kidneys, with really dramatic increases in levels both of sofosbuvir and its active metabolite, this 007 metabolite. However, it's controversial about whether we can use it in patients with a GFR less than 30 because the toxicities related to this very severe increased level have not been clearly demonstrated. And I'm not going to go through the whole literature about this, but there's probably even more data that's going to come out in the next year about how to actually dose sofosbuvir in patients with low GFR and on dialysis. And so that may actually not be true going forward, but at the moment it really is contraindicated unless it's extenuating circumstances. Okay, so that's pre-transplant treatment. We can do it if that's what we've decided is best for the patient. But what about waiting to treat till after transplant? Or what about all the patients that we've already transplanted that are still Hep C positive? And the medications are incredibly effective and efficacious after transplant. The main thing that we have to be concerned about in terms of choosing a regimen is actually drug-drug interactions. So one of the classes of the Hep C medications, the protease inhibitors, in general, although to varying degrees, but in general, have pretty significant interactions with the calcineurin inhibitors. So this is a very important interaction to consider. And so you can see here that most of the medications that can be used with sofosbuvir really have minimal interactions, and these are the medications that in general have been studied in post-transplant populations, both kidney and liver primarily, and can be used safely without dose adjustment or really many other considerations. It's the protease inhibitor regimens that are the ones that get us into trouble. So if a patient has recurrent kidney disease after transplant with a low GFR and you're unable to use sofosbuvir, then sometimes we use these protease-based regimens, but then you have to think a little bit more clearly about what their immunosuppression is and whether it can be dose adjusted. The main interaction that we think about is that these protease inhibitors, especially the ones that are ritonavir boosted, raise the levels of tacrolimus and cyclosporin. So in some of the early post-transplant trials, we went from giving patients multiple milligrams of tacrolimus twice a day to 0.5 milligram every 7 or 10 or 15 days. That's the level of this interaction. It can be quite severe. The newer generation protease inhibitors, this is less so. In addition, some of these agents, some cyclosporin in particular, also increases the AUC of some of the antiviral agents. So there's a whole class of antiviral agents that are actually contraindicated with cyclosporin. So in a patient that can't be on tacrolimus and has to be on cyclosporin for some reason, this is another thing to consider. That said, there are some post-kidney transplant trials. This is sort of one of the most formal ones. There's lots of real-world cohorts and data sets that show post-kidney transplant hep C therapy is very effective. This is a trial with ladipasvir and sofosbuvir, or otherwise known as Harvoni. This medication combination has been used in a lot of the post-transplant trials because of its favorable side effect profile and its lack of most drug-drug interactions, including with the immunosuppression therapy. So this was, patients were actually randomized to either 12 or 24 weeks. Neither arm got ribavirin. These were post-transplant patients that were at least 6 months post-kidney transplant. And basically, although some of those bars look a little uneven, across the board, 100% of people were cured. So this was like the first trial that basically showed us that this type of range of response is possible even on patients with pretty significant immunosuppression post-transplant. Many of these patients were also treatment experienced and had advanced fibrosis and other things. And again, overall, it was incredibly well tolerated. So the current recommendations for treatment after kidney transplant include sofosbuvir and ladipasvir for genotypes 1 or 4. Again, that's sort of a genotype-specific regimen, or GP, which is based upon another small study that's only in abstract form but will hopefully be published soon, post-kidney transplant, which is a pan-genotypic regimen. If you had to, there are alternative regimens that are available, also that are pan-genotypic, but just have a little bit less data, so weren't the first-line recommended regimens. So this leaves us in a new place for hepatitis C and kidney transplant, because really we're almost 100% confident, especially now that we have salvage regimens, that we can cure almost everybody, even patients on dialysis, with anemia, with comorbidities, with lots of other medications, and even patients directly after kidney transplant on high-dose immunosuppression. So the question really is when to treat those patients, not whether they're going to be cured. And so this is sort of a general algorithm that we use at Columbia to try to risk stratify patients we see who need a kidney transplant who have hepatitis C. So first, we have to determine whether they have advanced fibrosis. And I think traditionally speaking, this is done with liver biopsy. You could debate whether there's a role for non-invasive assessment of fibrosis. But I think in this day and age where you really need to know the stage with 100% accuracy, or as close as we can get, that liver biopsy is still often used. And patients that have minimal fibrosis, then, I think kidney transplant obviously is a good option for them. The question is, are they going to benefit more from being treated while they're on the list or after the transplant? And that question, I think, hinges upon what is their access to transplantation. Because in current status of affairs, and especially in our region, but probably nationally, patients that remain viremic on the transplant list and are willing to accept a hep C positive organ are going to be transplanted much faster than patients that don't want to accept a hep C positive organ. So if the patient doesn't have a living donor available and needs transplant soon, we are often treating after the transplant rather than before. Of course, if access is not a problem, either through living donation or because they've been on the list for a long time, then treatment before the transplant is great because then the transplanted kidney never sees the virus, and you can minimize any risk of viremia either to the kidney or liver in the setting of immunosuppression. In patients with advanced fibrosis, we go on to assess whether they have portal hypertension based on transjugular measurements of pressures, whether they have synthetic dysfunction, varices, any signs of decompensated liver disease, and then we have to make a decision about whether they need dual organ transplantation versus not, which is sort of another algorithm entirely. So obviously, as we've discussed, there's risks and benefits to both sides. Pre-transplant treatment, you might improve or stabilize liver function or even kidney function if some of the kidney dysfunction is related to the hepatitis C itself. You might improve waitlist mortality because we know that SVR increases your chance of surviving overall. And you minimize or eliminate the risk of rapid liver disease progression immediately after the transplant. The flip side is that post-transplant treatment may allow you to expedite the transplant itself. And in a setting where, an insurer setting where maybe you're only allowed one chance at treatment, it's possible that post-transplant treatment rates are even higher than pre-transplant. So I'm just going to touch on the use of Hep C positive organs for donation. So Hep C positive donors have been used for a long time in Hep C positive recipients. And I think the literature of this is very difficult to interpret because there's a lot of confounders here. But in general, their outcomes might be a little bit worse than Hep C negative donors. However, that was in the setting, obviously, of not being able to treat Hep C post-transplant. And I'm just going to put this up here very briefly. There's been a lot of press lately about using Hep C positive organs in negative recipients, which is a whole new paradigm that basically is based upon the fact that we now feel that we can cure everybody. And there was a consensus conference that I participated in where we talked about a lot of these issues, including the need to rename how we identify patients with Hep C, both in donors and recipients, on the list in our national data sets, because right now it's based on serology rather than viremia. And one of the reasons this is so important is because we have we haven't seen an increase in donation related to the opioid epidemic. Many of those patients, unfortunately, are actually infected with hepatitis C, and this has led to a dramatic decline in the age of organ donors that are identified as Hep C positive. And in fact, many of these donors are possibly otherwise completely ideal candidates for donation and have not had hepatitis C for very long, making it so it's unlikely for them to have lots of organ damage related to that. So there are studies ongoing. This was the first one published in the New England Journal where they took 10 negative, Hep C negative kidney transplant patients and actually transplanted them with 10 Hep C positive organs. They selected the patients, the recipients, very carefully as people that they thought were sort of underserved by their position on the wait list. And this was a study that was funded by Merck, so their availability of the medications was guaranteed. They had a very intensive informed consent process, and basically they cured 100% of the patients immediately following the transplant with very good outcomes. This study's ongoing. There's other studies that are starting too, some that we're going to be participating in kidney and liver, but it's a hot topic. I wanted to close with just a few thoughts about hepatitis B. It's not been clearly as dramatic a period of time for hepatitis B therapeutics in the recent past, but it's important to know that hepatitis B is also overrepresented in dialysis patients, possibly also because of the ongoing risk of exposures from contact with medical care and dialysis and transfusion. And it varies a lot depending upon the underlying prevalence in the population and the risk factors of the population. Certainly, there are also outbreaks that are documented in dialysis centers each year. So hepatitis B is incredibly important because in hepatitis B patients that undergo transplant, without antiviral therapy or control of the virus levels, you can get very, very severe forms of liver disease that can be fatal early after organ transplantation. So before we had antiviral therapies that worked well, this was actually considered a relative contraindication, at least in liver disease, but now things have changed a lot. So all patients being evaluated for kidney transplant and any immunosuppressive therapy absolutely have to be screened for hepatitis B infection. And screening is not just surface antigen. It's surface antigen, which is a marker of active infection, surface antibody, which is a marker of immunity, which is important because everybody who doesn't have that should be vaccinated before the transplant, and core antibody, which is a marker of past infection. and then hepatitis B DNA testing among everybody that you think actually has active infection. All candidates that have active hepatitis B should be started on antiviral therapy with an attempt to control their disease before they're transplanted, because again, immunosuppression after transplant can lead to really devastating outcomes. And the current paradigm for treatment really includes tenofovir and entecavir as the main therapies because of their limited toxicities and their high barrier to resistance. And once treatment is initiated, at the moment, it should be continued indefinitely after the transplant. So we don't think about hepatitis B cure the way we do hepatitis C, although there's early trials looking at medication combinations to do that. The one thing I wanted to update you on is a new formulation of this old drug tenofovir, which is a prodrug formulation, which is called TAF. It was recently approved as Vemlidy for the use in hepatitis B. And in head-to-head trials against the traditional tenofovir has similar efficacy in terms of antiviral effects, but it was really formulated to limit tenofovir-associated toxicities, which includes renal disease. So in basically all the studies that have been done to compare these two head-to-head, there's a very significant improvement in kidney function. Even if you switch people from the old tenofovir to TAF, you see a rise in their GFR. So this might be an important drug that we're switching a lot of our patients to after kidney transplant if they have hepatitis B. And in fact, the European guidelines were updated to favor this, particularly among patients with renal disease. And this is really my last slide with information about this approach, which is that hepatitis B is complicated. So you have to look at this panel of serologies, both for the recipient and for the donor, to figure out who to prophylax. Not going to go through the sake of time all of these different nuances, but these have been published in AJT, which is a joint endeavor by the communities of practice with liver disease and transplant ID within AJT. And it's important to follow these guidelines, both for donor and recipient serologies, to make sure you prevent hepatitis B transmission. So in summary, hepatitis is still incredibly important. It's much more prevalent in dialysis patients and transplant recipients and also in organ donors. We have a lot we can do now to treat and prophylax people from having problems related to these viruses, but it requires screening and testing and being updated on the treatment algorithms. Thank you very much.
And we'll have questions for the speakers. We're a little bit over time, but we'll try and have some questions. If you identify who you'd like the question to be for. Yes, we'll start here, please.
Regarding Dr. Kasiski's talk, and my disclosure is that Bert and I have been working together for how many years? 10, 15 years? Maybe even longer than that in Minnesota. So the comment is the following. The results of many of these prospective studies are currently discussed. We can't hear you at the back. You can or you cannot? You cannot. I'll stand right next to Dr. Friedman and you can hear me better. So the comment that I have to make is with regard to the studies that Dr. Krasiski showed. They are currently a hot topic, I mean, in general surgery circles almost everywhere. And they're being discussed as to the indication of surgical cases, as to the age of surgical cases, and so forth. Now, with kidney transplantation, despite the fact that we consider it a standardized procedure, there is one note of caution, and I think Dr. Kasiski expressed that by really asking for a prospective randomized study, and that is the following. The risk of fatal MIs, or MIs in general, is not only increased by the surgical procedure itself, and obviously the complexity of the procedure plays a role in what the incidence of these MIs is. But in the specific case of kidney transplantation, it's also the fluid shifts that happen during the surgery. Intraoperatively, we frequently fluid overload the patient in hope that we can avoid ATN. And that leaves the patient on the table even before we close the patient, whose weight is up 4, 5, 6, 7 kilograms or more than that. So I think without a prospective randomized study, which is very difficult to conduct in transplant circles, we may have to wait until we say well, we don't think that screening for cardiac disease is warranted or no longer warranted. The question that I have for you, Bert, is you showed this interesting slide about outcome from Spain in donors that were over 75 years of age. That goes actually back into the 70s, 80s, when George Abuna showed, and he took on all kidneys that no other center in the United States would use, that graft survival was still over 70%. The problem with that is, and we all would probably like to do more transplants, but we get dinged by UNOS, through the SRTR data, because they will really show us, less favorable graft survival. So will be there a mechanism in place, or can we work on a mechanism that transplant centers are not penalized if they take these high-risk donors 75 years and older? The second question that I had for Dr. Werner.
One at a time, and let's get a brief answer. We will have no questions if you continue.
I agree.
Okay, okay, okay. The panel should feel free to interject their own opinions. Dr. Tedler has kindly allowed an additional 15 minutes for this discussion with our distinguished panel, but I would like to keep it going so all of you can comment as you wish and make your responses brief and concise, please. Any additional comments on this point? Please ask your question. They may not hear you. Do you want to? The question is it contraindicated to use an HIV positive donor? Could you use the microphone, please?
Columbia and Mount Sinai are both sites for the Hope and Action trial, and Mount Sinai's already done a couple kidneys. Yes, my question is for Dr. Kisiske. Can you please comment also on the assessment of systolic ejection fraction or pulmonary venous pressure to assess for perioperative morbidity and mortality in these patients? And my second question is, you mentioned statin use, but we have had randomized trials in end-stage renal disease patients, like the 4D trial, which did not really show any difference in outcomes. Thank you.
Right. First, the statin trials have, in the dialysis population, have been, what surprised a lot of us, negative. And it's raised the whole question of, what is the reason for that? And is it because vascular endpoints in the dialysis population are really different? They're not as front. Maybe it's more of, heart failure type of endpoint rather than atherosclerotic we're all believing that stats are beneficial in high-risk transplant decisions. So given that, if you have a high-risk patient you're transplanting, you're probably going to run a statin.
The panel should feel free to cross-comment, please, and give your own additions or disagreements with whatever is said. Thank you.
I just wanted to follow up on that.
Could you get to the microphone, please?
As a follow-up to that question, what I always worry about comparing transplant patients to patients on the waiting list. And I'm wondering whether what you're seeing is not that the transplant patient is doing better, but that we don't do a very good job preventing cardiovascular disease in dialysis patients, which pretty much speaks to what you just said about our poor understanding and the discrepancy in the findings in use of statins, et cetera.
Right, there's been a lot of studies, observational studies of results after transplant compared to being left behind the waiting list. And there's certainly a potential of bias. For example, if patients aren't transplanted and they're not taken off the waiting list, then it may be a biased population with worse outcomes. But the results are so dramatic that it may dilute it out somewhat. But to see 5-fold, 10-fold improvements is really dramatic. It's hard to imagine that bias would increase. So I think most of us that look at those data still believe that the outcomes are substantially better for transplant compared to
Thank you. Dr. Jonathan Marmer, please.
Oh, yeah. We do the cardiovascular screening here for the transplant population. So,
Could you speak a little louder and hold the mic a little closer?
I don't know if this mic is working, but we do the evaluation for the transplant from the cardiac perspective. From our perspective, as cardiologists, we generally say that revascularization in a preoperative population should be no different from a non-preoperative population. What we're really looking for is instability. All those studies you talk about that show no benefit of revascularization, they're really looking at a stable population. The whole literature has shifted if it's an unstable population. So one of the things we look for on an annual basis is for instability in their symptoms, and not infrequently we find actually there's been a change in symptoms. So they then fall into a different category. The other thing is that it's not just a matter of coronary artery disease. Of course, these patients are at risk for valvular disease, in particular aortic stenosis. And another thing that we found is not infrequently the pulmonary pressures on echocardiography are quite elevated, and that can change the amount of fluid that would be taken off at dialysis to put the patient in a better preoperative state. And what we find is a rate-limiting step is the anesthesiologist. If the patient isn't perfectly primed, it could be an obstacle to getting that patient on the table and use that kidney. So I guess my question to you is, how often does your group see these patients? Are the cardiologists seeing them once a year, once every 2 years, once every 3 years? What is your routine? And how often are you finding problems on the screening that lead to significant changes in management?
Well, number one, I agree with you certainly that if the patient's not stable, then sure, you do the optimal management that you would with any other patient that's having an unstable engine or basically unstable. You raised another interesting question about valvular heart disease and fluid status on dialysis. And the cardiologist that I've worked with over the years, is you probably know him, Chuck Herzog, who is an echocardiographer and believes strongly in doing echoes, and based on that and the assessment of the patient will often want a right heart cath, perioperatively to manage the patients. I'm always throwing the gauntlet down and say, well, what evidence do you have that this improves things or improves outcomes? And of course, there's not been evidence to that effect, but it is certainly a reasonable approach that I can't argue with.
Thank you. We have a question in the first row, but I wonder if the three of you would just raise your hand if you would do a kidney transplant in a patient with hepatitis C. Yes, I would. No, I wouldn't. Yes, I would. Okay. How about hepatitis D? B, I'm sorry. Okay, thank you. And question from the first row?
Well, actually, that's a good segue. So my question is to Dr. Verna, and looking at the Thinker trial and also knowing what we now know about the hepatitis C agents that we have.
Could you speak a little louder and into the mic?
Sure. Knowing what we now know about the results of the Thinker trial and thinking about the agents that we have, do you think that, and the long wait list, do you think that we should be going prime time with talking to our patients on the wait list about taking hep C positive kidneys? Or is there more to learn yet?
So this is an important question that's being debated a lot also in liver transplant these days. I definitely don't think it's ready for prime time. And maybe I'm the more conservative end of this, but the results of this consensus conference, which brought surgeons and medical doctors from all different areas in infectious diseases, but also payers and representatives of UNOS and other people to this conference, was that we need to do this in a way that we can learn from it and understand what the risks really are. So yes, we think we can cure upwards of 95% of people, but what happens to the 3 people that we can't cure in the first 6 months? And that consent process is very difficult right now because we actually don't have any data to tell the patient regarding that. And I think the other major obstacle is the availability of the medications, which we didn't have time to really address, but there's been lots of articles in the Times and elsewhere about how 12 weeks of Harvoni costs $100,000. And so it's someone that you give the infection to with a medical procedure to then go back and ask the insurer to pay for that is not a slam dunk. In fact, I have post-transplant patients that I still have to fight for 3 months for the insurer to just get standard of care therapy for someone that was viremic before I met them. And so that is a huge obstacle, and it's variable region by region. It's variable depending on what type of insurance you have. And so, we sort of advocated that right now doing it in the setting of controlled trials where the medications are available and we can time everything and really learn from it the way we want to do it is optimal. Not all of the centers are going to have those trials. And so what do those folks do? We're going to have a trial, but we put a clinical protocol in place for liver and kidney where we ask the insurer before we consent the patient to be listed in a way that allows them to accept these organs. And we're just trying to figure out how to deal with insurers in that way. In other parts of the country where the insurer is part of the hospital or where, like in Kaiser, where they're insuring a large proportion of the population over a long period of time, deals have been made to try to do that, but the availability of drugs is the Achilles heel of that approach.
We have 2 audience questions for you. Dr. Clinton Brown, please.
Just to follow up on the use of statins in end-stage renal disease, I think the issue is that LDL cholesterol really is the wrong target for people with end-stage renal disease, and HDL, high-density lipoprotein, has multiple functions like antioxidant, it's repairing endothelium, antithrombotic, anti-inflammatory. But we don't have a good way to measure HDL function. And I think HDL dysfunction is the problem with people with end-stage renal disease, not LDL cholesterol.
Yeah, I agree. In fact, in the dialysis population, one of the questions that's come up, well, what should we do next if the statins don't appear to be all that effective? One of the answers might be some of the newer agents that really modify cholesterol ester transport and whatnot that are out there. Maybe that's a population, heaven forbid if you get to degree because it's high risk for a number of other reasons, but maybe that would be a population to study some of these newer anti-lipid therapeutic approaches that I think you're alluding to.
And Dr.
Could you comment?
Did that answer your question, Doctor?
Yes.
Okay. Dr. Mary Malopoulos, please.
Could you comment on...
Do you have the microphone?
Yes. Could you comment on contrast-induced nephropathy if you eliminate...
Can you hear her?
Can you hear me?
Could you speak a little louder and directly into the microphone, please?
Could you comment on
Thank
the...
you.
Sorry, went up too loud. Could you comment on contrast-induced nephropathy in the transplant population if you eliminate preemptive clearance? Dr. Kasiski.
You mean in terms of taking contrast for...
Right, with a cardiac cath after.
Yeah, at least in my experience with our cardiology nephropathy has been really low. I mean, it's been well managed. Often they'll do things like stage procedures and whatnot, but they've managed to get the incidence down to a very low level. In fact, we looked at it at one time at an abstract, but it was like virtually non-existent. So yeah.
Could you comment on what do you think would happen if you eliminated the preemptive transplant evaluation?
In terms of if you didn't do as much screening and angiography?
Right, beforehand, and if you just waited till disease happened, do you think it would go up?
Would that increase the, I suspect not. Because I think patients will be better after transplant. So I don't think you would have a deluge of perioperative or immediately post-transplant procedures. Obviously, I'm just guessing that they're speculating on that.
I think there's one study which has about a 5% incidence of contrast-induced nephropathy right now, but and this is with people just getting it on an emergency basis, for CAT scans and so on and so forth. So that's just something.
I'd like, as Dr. Tedler says, we are about to end, I'd like each of you to come up with one take-home point. It can be two if you want. The key points of the discussion as you understand them, that from your three presentations, what would you like the audience to take home? Let's start, please.
Viral hepatitis is incredibly common and underdiagnosed and needs to be screened in dialysis and also in transplant candidates and recipients, but it's eminently treatable. So as a hepatologist, my viewpoint is diagnosing a candidate with hepatitis C does not mean they're not going to have a successful kidney transplant. It's just a matter of figuring out the best time to treat them.
Well said, thank you.
My take-home point is simple. We wouldn't have transplantation without donors. So the idea is to identify, maintain, and ensure that we have donors.
Thank you.
And my belief is for evidence-based medicine, it will be nice to see the ischemia CKD trial results, and as well as all the other aspects of reducing risk from cardiovascular disease.
And I'd like to give the audience's thanks to the three of you and how fortunate we were to have you find your way to Brooklyn. Thank you. Thank you.
We will have a short break to make up the time. Please come back in 5 minutes at 11:50, and we'll start with the next segment.